Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Farden, and I'm the chair and organiser of Grand Rounds. I'm dialing in from home today, as you can probably see. Well, we were expecting Lake Khalif, who's the director of NHS Digital Services, to be starting off the presentation, but I can't see him on the list of people who are signed in at the moment. Lake, if you're there, could you let us know? Doesn't seem like it. So we may just move on to the second speaker of the day, who's Emily, who is here. So the introduction to Emily's talk is that earlier in this month, I was approached by some of our medical student colleagues asking if we were planning on doing any grand rounds which focused on Black History Month, and so we are doing that to support the university in its program of Black History Month themed talks. And next week we have a talk about obstetric complications for Black and minority ethnic women, and I thought it would be an interesting thing if we could do a presentation about the medical differences that face people who from Black and ethnic minority backgrounds, and looked at my own speciality here in respiratory medicine. And I'm very pleased that Emily Ward, who's one of our registrars, is going to give a presentation, which I think is, I hope you'll view as a starting point for discussion about the differences in race and in ethnic background in medicine, something we don't often think about, perhaps don't think about enough. And Emily is going to give a presentation on the differences in respiratory medicine. I should try to sort of forewarn of this, that I don't think either of she or I profess to be experts in this area. We're interested in this area, and we want to try to just highlight that we are thinking about these issues. There is research that's gone on to look into these issues, but it's just the beginning of a journey. So Emily, are you there? Can you share your slides and we'll get going?
Yeah, great. Just let me... And I'll just have to minimize you all so that I can actually see what I'm saying. So hi, thanks very much. I think Tom's introduced me there. And certainly, like I say, we don't profess to be experts, but I really hope that through this we can both learn something. So this Grand Rounds looking at Black and Asian minority and ethnic background in respiratory inequalities. And my aim essentially is to show us that we know that there's disparities in respiratory outcomes and race, and it is vital that we try and understand these greater in order to address how we can improve these, and without understanding these differences we can't make those improvements. I also want to say at the beginning, so I understand that for some people this topic's really very sensitive and it's very personal, and I hope that most of all I can talk to you in an inclusive manner. And it's interesting, at no point do I cause any offence for what I say, write or discuss. And obviously happy to take questions at the end, so hopefully you enjoy. So our content essentially is just to look a bit at Black, Asian, minority, ethnic background and race. I've called respiratory tools, looking at some of the equipment used in respiratory, and we touch on asthma, COPD, lung cancer, and I don't think you can do a respiratory kind of global talk without touching on TB, a slide on COVID, and where next and where are we looking at. So that's what we're going to hopefully run through. So first of all, just thought I'd set the scene for the UK. So this is the latest, it's 2011 England and Wales census, which you can see the different ethnic groups or racial groups down the left-hand side there, and they make up 19.5% of the total England and Wales population. Scotland gave us a rather prettier map. As you can see in the Hebrides, the very light area of blue, it's under 0.5% of ethnic background, and that's anything that's not Asian or white other. And then in Dundee and the majority of Scotland, it's 0.5 to 1%, and anywhere dark, so Edinburgh, Glasgow, up in Aberdeen, is 1% or over, so that's the dark blue there. I'm just setting a bit of a scene. So we don't have a huge population of different races within Dundee, but we obviously have some. I reached out to a good friend who does public health and is very knowledgeable and background on race, and she pointed me towards this book, which I haven't actually managed to read yet, but read a lot about, and it's by Angela Sani, who talks about the return of race science and gives us a really nice summary of race as a background and a concept, in a way that I hadn't thought of it before, so I just wanted to present that. Really talking about how it was back in 1758 that the categories of race as such, split into Americas, Europe, Asia, and Africa, are recognized by their supposed characteristics, and describes these what seem completely unimaginable to me now, but 20th century essentially human zoos, where scientists would go around and take measurements, eye color, head circumference, etc., of different populations from different areas across the world, and people could literally go and attend and look at the population. But we know through history, not just through World War II, but so many significant events in history, and through people's own personal experience, that race is being used in many, many ways to be detrimental to populations. And in 1950, UNESCO convened some scientists who concluded that they should try and put an end to racism, racist research, stating that scientists have reached general agreement that recognizing that mankind is one and that all men belong to the same species of Homo sapiens. But we cannot now ignore the fact that the social construction of race exists and the inequalities that have been based upon it. And hopefully through this talk, we can learn a bit more about that. I also wanted to just touch, because a lot of the audience here will be working in education, on the social identity theory of implicit bias and how potentially race can affect our consultations. So a study in 2017 by Fitzgerald and Hurst looked at the potential dissociation between what you explicitly believe and want to think and the hidden influence of maybe negative implicit associations affecting your thoughts and actions in a way that you aren't necessarily conscious of. Zescott in 2017 showed that different ethnic and racial differences have been observed in multiple different health and social outcomes, to show that there's ways in which implicit bias is throughout our society. A lot of the studies that they reference to are studies, hypothetical ones. So for example, at a large conference in America, they might ask all of the general practitioners, how would you treat this person? They'll give them X, Y, or Z clinical characteristics and present a different race of person, and they show that there are disparities in what people say they would do by ethnic backgrounds. And that's predominantly looking at, hopefully you can see path A here, judgments about decisions about patient care. So it's just snap decisions in these hypothetical pathways. And obviously a far better way, in keeping with a lot of this realistic medicine style practice that I think we all try to do in Scotland, is that to build up communication and trust with patients and to actually discuss what patients want to do to try and reduce disparities in health. But you still potentially will have implicit bias in that. And the authors also acknowledge that people who are high risk of having implicit bias are less good at communication skills. So it's just a bit about recognizing there is something called implicit bias and developing strategies, e.g. reflective practice, to try and manage these. And then finally, the issue of self-reported race versus genomic research. This is an article from 2014 in Human Genomics, and I wanted to use their terminology because I was fairly certain I'd probably get mine wrong. They use race to refer to a person's physical appearance, such as skin color, eye color. Ethnicity, on the other hand, looking at the cultural differences, language, social practice, and variabilities in traditions. And then genetic ancestry, looking at ancestry markers and how the phenotype of race and ethnicity is often in disagreement to genetic ancestry. And we know that we all have much more in common with our fellow humankind, and potentially some self-identifying African Americans may have up to 99% European ancestry, and it doesn't mean that they have no way right to identify as African Americans, but it's just that the ancestry markings are different sometimes to what we might expect. And then I don't think you could really get away with trying to talk about genetics, disease, environment without having a little Venn diagram just to really show that so many of these things are so interlaced. And I think I'll hopefully show this throughout the diseases that we show. So very quickly, just touching on the respiratory equipment I talked about, there was a fascinating article by Braun in 2015. It goes back through the sort of history of spirometry, and in just talks initially in the introduction about how while we adjust for height, weight and sex, the correction factors of 10 to 15% for individuals who are labelled Black and 4 to 6% of people labelled Asian. And often that's just on a simple eyeball, or like I say, or as we've said before, verbal communication of what people identify as. And really just thinking about the differences in why that's occurred. Back in the 19th century, Thomas Jefferson in America said that there was a structural difference in the pulmonary apparatus. That wasn't using spirometry, that was just a theory. And in the 1800s, when spirometry was being developed, they couldn't just explain all the variability in different spirometry by height. So one of the London physicians studied occupation, which led on to a study by Cartwright, who looked at the differences in lung capacity between slaves and white, finding in this population a 20% deficiency in slaves in their description, which and hopefully you can see now the spiral and the snowball. The Hoffman from insurance then, so a very large insurance company in the States, then said that smaller lung capacity of coloured race is proof of an inferior organism. And you can see how it's snowballing from that one bit of research, and challenged by some South African researchers who questioned the interpretation and argued that it didn't take account social and occupational conditions. They've never quite managed to write this out of respiratory spirometry values. And if you think about that, if you look at occupational lung disease and say you're using FEV1 as a measurement of a potential occupational exposure, if you say that a certain category of people have a lower FEV1 in the first place, and then you look at whether or not they've had occupational exposure, they may have, if they weren't lower in the first place, they may be detrimented, and it doesn't show such a large difference from the occupational exposure. So it's really just showing that these are reflecting assumptions of genetic differences, and potentially we should be asking different research questions. And I just thought, well, what are we doing now? So 2011, American Journal of Respiratory and Critical Care Medicine essentially said that while they acknowledged that there needs a lot more research, they felt that they still required race-specific equations in spirometry. The New England Journal of Medicine in 2011 felt that actually people who identify the genetic ancestry is more likely to provide differences in lung function than people who identify on self-reported ancestry alone. So really, how do you do that? Do you do genomic studies for everyone doing spirometry? And then in European Respiratory Journal in 2015 showed that individuals with a high percentage of African ancestry had a lower lung function than those with less African ancestry, but they felt that this was potentially explained by differences in height. And I just had a wee look at the guidelines for now. So we tend to always talk about variability in FEV1, FVC ratios and things on age, sex and height. But actually the 2020 March guidelines from NHS England give us a clear table of how we should be affecting our reference values as per ethnic population, which is shown below. And these correlate to the 2012 European Respiratory Society guidelines that state that essentially anyone from these same category should have a reduction in value by a factor of 0.9. Although they do then go on to explain that potentially the lack of nutrition for those born in poorer countries may be ruled out by second generation, and therefore you might not need to do it during that point. So I just thought it was interesting, and certainly our modern equipment does adjust for that. And then cyanosis and SATS probes, I wish I had better pictures to show you, but the lack of pictures reflects the lack of education out there. is that blue lips might be associated with cyanosis in somebody with a pale coloured skin, but blue lips don't necessarily associate with cyanosis in somebody with a darker coloured skin. And certainly we've had colleagues tell us that, you know, when they speak to NHS 24, various things, they're asked if their family members are blue. It's just a completely inappropriate question. So I don't have decent images to show you, but hopefully that's something that might change as we go forward in the future. Then talking about about SATS probes. So back in the 1990s, some South African physicians studied 100 patients with darker skin versus those with albino subjects, but they only ever used SATs of over about 88%, because they weren't trying to actually cause hypoxia, and they didn't find any difference in SATs probes. But when that study was repeated, and actually it was much smaller group of people back in 2005, and they hyperventilated on nitrogen oxygen and a CO2 mix to reduce their saturations. Hopefully you can see on the left of this graph that there's actually quite a disparity in people with darker skin have a much greater difference, and their saturation readings will read higher when they're actually lower, and this is a disparity under 70%, and thankfully more normalized in the more normal values. So yeah, just touching on conditions now, and I've chosen asthma, COPD and lung cancer partly because there's data out there, and partly because I suppose they're you know, our biggest ones. So asthma, there's been the collaborative study of genetics on asthma, and this was done you know, back in the sort of late 1990s and published 2001 in various different formats. So 266 families of African American, European, African and Hispanic descent. You may not be able to see, but essentially these are the different loci that are associated with having asthma, and they looked at families with 2 siblings with asthma, obviously some standardized controls for the diagnostic of asthma, and ruling out things, you know, confounding factors such as smoking. The second line down is African American, the loci that are associated with asthma, then it's Caucasian, and then it's Hispanic. So they did find susceptible loci with disease varying across different races, and from the same cohort of people, essentially, but 314 families, and this time they actually split down and showed us what the different groupings were: 46 white, 41 African American, 13 Hispanic. They looked at the clinical characteristics of this and the level of bronchial responsiveness, and also whether or not they had family members affected. And I just wanted to put in there as well that in order to belong to a certain group, you only needed one parent to belong. So if one parent was Black African American, then you fell within that group. So they found that the African American pairing siblings had a lower baseline of FEV1, and Hispanic pairs had more skin reactivity, whereas the white pairs had lower serum IgE, and there were more relatives among the African American families than among white and Hispanic who also had asthma. So again, seemed to link race with having the disease. But asthma, as we all know, has such a huge social confounding factor. So what is the social impact of this? In 2017, Academic Pediatrics looked at 33,000 households, teenagers of 6 to 17, looking at race, but also social factors in regards to asthma diagnosis and emergency department visits. And when they compared the racial disparities in asthma to maternal hardship, and specifically they were looking at poor quality housing crowding, they found that there was a significant reduction in the sort of effect of race, in that housing actually had such a significant impact on the development of asthma that you were starting to rule out any change in race. They did find that there was still an increased odds ratio in non-Hispanic Black households having a child with asthma and emergency department visits. So it was still there, but it was very significantly limited by housing and socioeconomic factors. And I wanted to put this study in because it's British, and we just really didn't have many British studies that looked at race and compounding factors. And this is 2017, some Imperial students who, so it was 112, they were white or South Asian. And they both had to have 3 grandparents born in the respective continents to be put into the certain groups, and they were done under similar socioeconomic environments and birth weights. And they found on average that there was a reduction in the FVC of 0.086, lower in South Asia in comparison to white. And interestingly found that first generation parental immigration, so essentially if one of the parents had been born outside of the UK, there was a larger effect on the FVC than if the parents had been born in the UK. So just a quick summary on asthma as such. So there's multiple studies showing that asthma, the higher rates of hospitalization, morbidity and mortality in ethnic groups, in particular Black groups, and because the studies are mainly done in America, Black American, genome studies do find different loci attributable to different racial groups, but they can't necessarily say that those loci are going to be completely factual in developing asthma. And studies demonstrating the lower FEV1 across different racial groups potentially linked to parental geographic birthplace. And then just another interesting study that hadn't gone through, but just showing that self-efficacy, essentially self-management of asthma, is also different across different racial groups. And if you're not aware, in asthma nowadays, every person should, in theory, have a written plan of how to manage their asthma as part of our sort of quality standards. So how a patient manages their own asthma has obviously a significant impact on their outcomes from it. Essentially controlling for social and economic standards with traditional measures using income and education definitely lessens the race effect in asthma, and furthermore maternal hardships such as housing also lessens that effect of race again. So I just quite like this summary from Neurology and Clinical Immunology of asthma, essentially that it's a phenotypically heterogeneous disorder with environmental and genetic factors, and I think that, you know, I suspect we'll not be able to pick those apart during my practice. So moving on to COPD. So COPD and genetics. In 2006, Chatila and her colleagues looked at data from the National Emphysema Treatment Trial, and this was set up essentially by a lot of American insurance companies when they started doing lung volume reduction surgery. It was very expensive, and they wanted to make sure that it was actually something that was working. So that trial was set up. Now this was, I'd just like to point out at the bottom, very small proportion of African to white. So it's 3.4% African American to 95% white, although of a reasonably large cohort of 1,218. And they found that African Americans were significantly younger, so 63 rather than 67, and smoked less when they had advanced emphysema. And this was something that was also found in 2011, so data from the African and European ancestry in the COPD gene studies, essentially looking for genes that are associated with COPD, found that there was a greater proportion of African Americans under 55 with an FEV1 under 50% in comparison to those over 64. And they felt that race appeared to be a risk factor for severe early onset COPD, but they acknowledged that they didn't and couldn't look at the environmental and socioeconomic factors to see whether or not they played a significant part in that. I can't talk about COPD without talking about smoking, I don't think. So the study of tobacco in minority populations published in 2012, a study about 32,000 people from different ancestry backgrounds to look at genetics and tobacco smoking. And they found essentially correlation between studies of European ancestries that implicate the similar chromosome 15q25 as most significant for smoking quantity. So I thought that was quite interesting. And then furthermore, to talk about smoking, the National Cancer Institute and the Journal of American Medical Association find differences in nicotine metabolism and lower clearance, particularly in African Americans and Chinese Americans. And the hypothesis is that potentially they have greater nicotine effects from a lower cigarette consumption, which may back up some of the previous studies about a greater proportion of emphysema from a lower smoking intake. And then just thinking about socioeconomic status and COPD then, so BMJ epidemiology in 2009, they found that the Black race is associated with greater COPD severity, but they did state that once you controlled for different socioeconomic status, you couldn't actually state that there was a causation of race with COPD severity. But they recognised that there was a huge a discrepancy in Black population living in lower socioeconomic backgrounds, and that lower education and lower income are particularly at risk of acute COPD exacerbations. So just for a summary from the COPD, the greater proportion of people with severe emphysema who identify as African American were found to be younger age, but they have similar chromosomal regions which account for quantity of smoking initiation and potential cessation success. Hypothesis that there's different metabolism of nicotine intake in different groups, and there's clear evidence to suggest that we all know that smoking status, is associated with lower socioeconomic backgrounds, both all across the world, really, and that in the UK and the US, the self-identified Black populations are more likely to live in lower socioeconomic backgrounds, so therefore more likely to smoke. And also there have been some American studies showing variabilities in what may motivate different race groups in stopping smoking. In particular, they found that spirometry values and having a physician seem to motivate people who identify as Black race more. So just moving on to lung cancer, I thought we all probably needed a table or some form of non-writing. And this is a 2017 Centre for Disease Control table for lung cancer from the States. And as you'll see on the left-hand side, that's the male, so 71.1 per 100,000 males developing lung cancer. So that's the highest group is Black African American males. And then in the females, the white group has a higher proportion. So again, just thinking about social effect, we've covered smoking, so I won't go over that. Meta-analysis from 2013 looked at 23 papers across basically across Europe and across America, and looked at lung cancer outcomes and socioeconomic factors. And they found that people with lung cancer who lived in more socioeconomic deprived communities were less likely to have any form of treatments, be it surgery or chemotherapy, but they couldn't account for these socioeconomic differences by different health setups, so essentially private versus social healthcare systems. That didn't account for the differences in people being worse off if they're from a lower socioeconomic background. And it was similar in 2017, California's population cancer registry study showed that the majority of people who suffered with lung cancer were non-Hispanic Blacks, who were more likely to live in the lowest socioeconomic status group. And hopefully something a bit positive here, that lung cancer incidence though has declined, and amongst all of the groups, although it has declined most in those living in the highest socioeconomic group. So race specifically, clinical oncology in 2016 looked at nearly just over 21,000 people, again, only 8.4% Black versus 91.6% white, and they found that there was a correlation between Black patients with lung cancer undergoing staging, and also for those who have undergone staging, less likely for them to then have surgery. And that's a sort of correlation there. They'll gain small numbers, and as you might expect, people who had less likely to have surgery, many other variables such as staging of disease. And this is something that was sort of similarly backed up in the Journal of Cancer in 2012. So their surveillance epidemiology and end results database from nearly 20 years looked at just over 170,000 people. And so they certainly found that Black mortality and actually white mortality was higher. And they were specific at this point looking at Hispanic groups to see, and interestingly, actually Hispanic groups do better despite being in a minority in America, and they feel like this might be the paradox, because accordingly they have increased family support, lower smoking rates, and because it tends to be that Hispanic populations migrate for economic reasons and therefore maybe send money back to home countries. They have a tendency to send people who are healthy, and if people become unwell and unable to work, they then maybe return to their country of birth, so therefore they would be lost to American studies. They also have seem to have a higher incidence of non-small cell lung cancer, which has better outcomes anyway. So as a general summary, overall, we know that the lower your socioeconomic status increases your incidence and reduces your accessibility to an outcome from treatment, but that there's also a disproportionate number of people from Black race who live in a lower socioeconomic status group. So therefore, there's a correlation between the two. The studies that look at just race find a disparity in those that go on to have surgical intervention. And again, just hoping to highlight some positives that since the 1980s, it's decreased lung cancer incidence in the States, at least, both in white, but also Black and across all social economic standards. Very quickly, just touching on TB, because I didn't think you could leave it out. Nicely geographically, you can see that clearly some countries have the higher incidence of TB, and this is the World Health Organization 2019 highest 8 countries. The leading infectious disease killer, top 10 cause of death worldwide, with a significant overlap of socioeconomic status, comorbidities and access to treatment. And I wanted to touch on this because just wanted to touch on TB in the UK. So a review of TB incidence in the UK in 2018 showed that 73.6% of individuals who are diagnosed with TB in the UK are foreign born, but actually only 0.35% are thought to have active TB in the time of their arrival to the UK. So a lot of this is reactivation of latent TB. But interestingly as well, of UK born population, if you're a non-white ethnic group, you're 3 to 14 times higher than white ethnic group to have TB. And I think that's probably they feel the study says that likely it's in action of kind of social norms and I suppose ethnicity rather than race there. But if you're homeless and in the UK, you're 20 times more likely than the general population to have TB. So I just thought we'd highlight that there. Actually, our inequities probably is not just on race. I thought that their description here on the right hand side of your screen shows you really nicely actually how and where actually as medical professionals we can intervene. So people have different exposure to the pathogen, but they also have different vulnerabilities in their backgrounds, comorbidities, social status, experience of migration, and then different treatment seeking behaviours, everything from stigma and cultural beliefs to barriers in access to healthcare, language, etc., how to use online platforms, for example, speak to NHS 24, etc. And then this is a slide. It's a short slide because essentially I just don't think the research is there and done yet. And it's obviously very poignant and memory to many people who've died with COVID-19. But this is the BMJ's pictorial one from April of different doctors who've died in the UK of COVID-19, and a study from the Health Services Journal in April 2020 showed that 106 healthcare workers, of the 106 healthcare workers who died at that point, 63% were from an ethnic minority background. And I'm not going to in any way attempt to raise any suggestions of why or how. And I don't know if anyone read the BBC article this morning. Certainly there should be, and I think will be, some more UK reports, and the BMJ are certainly pushing to try and find some more answers. So it'll be interesting to see in time where that goes. So then just moving forward, so just a couple of quick slides. So tools, what can we do? As hopefully I've shown you, there's a huge amount of discrepancy in socioeconomic status. So this is the Health Equity Assessment Tool in Public Health England, or no longer, that was created in March of this year. So it looks at socioeconomic groups, but also characteristics of the Equality Duty Act, geography, and inclusion of health and vulnerable groups. And if you do have a group that you feel fit into this, there's performers and things online for how essentially you can try to reduce your inequity. And if you haven't seen this picture on the right before, I think it's just a really nice pictorial evidence of inequality essentially versus equity, which just gives a nice summary of, I suppose, what I'm attempting to try and say there. So moving forward with race-conscious medicine, in this article was sent to me. It's written in Lancet in October of this year, and Sedena and her colleagues state that race is often a learned and dependent risk factor for disease rather than a mediator of structural inequalities that result from racist policies. And just to think of an alternative approach that emphasises racism rather than race as a key determinant of illness and health, and encourages providers to focus on only the most relevant, and pushes and urges clinical journals that rather than using race as a proxy for biological variables, which we've proven, I think, it isn't. They need to use genetics, pharmacokinetics, and metabolism to actually use accurate differences. And then finally, because I think this says it far better than I do, the 2019 American Association of Physical Anthropologists, race does not provide an accurate representation of human biological variation. It was never accurate in the past, and it is never, and it remains inaccurate when referencing human populations now. We're not divided biologically into distinct continental types or racial groups, but the Western concept of race must be understood as a classification system that emerged from the support of colonialism, oppression, and discrimination. It does not have its roots in biological reality, but has policies and discrimination, and because of that, race has become social reality, and it structures societies and how we live. And in this regard, race is real, as is racism, and we have real biological consequences of this. So thank you very much, everyone, for listening. Thank you to my friends and colleagues for sharing their insights and papers, and there's lots of references at the end there. And I don't know how this works, but happy to take questions.
Emily, thank you so much for doing that for us today. I'm acutely aware that I leveraged you into doing this at relatively short notice, and I think you did a really nice job there of just taking us through some of the evidence and making it and giving us some questions to think about. You know, when teaching medical students about TB, obviously we always we're trying to say that just because someone has recently travelled back from Pakistan and has a fever and a cough doesn't mean to say they have TB, but often they do have TB. But you'll know we have just as much TB in the homeless population that's white, Scottish, local, as we do with people who have recently come back from a high risk area. So does anyone have any questions or comments from the audience that anything like to share, or any questions for Emily? There was an issue in asthma in the mid-noughties, because there was a study called the SMART study that showed that Black African Americans responded very poorly to long-acting beta agonists, and this became very big news because the guidelines clearly showed that we should all be using long-acting beta agonists as second-line treatment for asthma, and they save lives, etc., etc. And ultimately, it came down to what we discovered after lots of analysis of this, was that it was not because they were Black, it was because most of these people were poor and they couldn't afford to buy two different inhalers. So if they bought just the steroid, they did well. And if they bought just the long-acting beta agonist, they did badly because they weren't getting a steroid. And this was very big news for a long time until somebody actually worked out what was going on underneath. And it was nothing about race. It's nothing about color of skin. It was about being poor and being able to afford to get drugs. And I think you touched on that very well during your presentation. There's one chat. Oh, someone is just saying you have a brilliant presentation, Emily, so that's nice. Another point which was brought up by a colleague to both of us, Emily, just last week, is that just because you're from African descent doesn't lump you together as being, Africa is huge, and being from a Nigerian descent is very different from being from an Egyptian descent, or from being from South Africa, and there are some guidelines which very clearly state if you're black, then you should have this drug, and if you're white, you should have another drug. And I think that's something that we need to really, really think about, because as you've said very eloquently, a lot of the way here, it just seems like nonsense. So does anybody else have any questions or comments? If not, we'll wrap up. I would just echo the comments in the chat. Emily, you did very well there. That was an excellent presentation in a difficult topic, and I'm grateful for you standing up to do it. Now, next week, one of our obstetric colleagues is going to talk about obstetric complications in people from Black and minority ethnic backgrounds, which I'm looking forward to. And then the following week, believe it or not, we're into November. It'll be bonfire night, and we're back to respiratory medicine, where my colleague, Professor James Chalmers, is going to speak about a drug I always pronounce wrong, but I think it's briscotinib. Anyway, he's going to talk about this new drug, which is an anti-inflammatory drug in bronchiectasis, which is also trialing in COVID, and he's going to come and talk about his paper in the New England Journal of Medicine. So thanks again, Emily. Thanks everyone else for coming. This will go online in due course, and I'll see you all soon. Thanks very much.